economist.
Okay, okay, we're ready for the next session. Okay, we're going to get now into one of the, as we think about the policy cycle, right? The policy cycle, we've been moving through not only the control knobs, we've been moving through the policy cycle. Okay? We're not moving through them exactly in the right order because after this we're going to look at implementation. But now we're looking at monitoring and evaluation. And we have two people who will be sharing this session. So it's my pleasure to introduce Edith Belenyi. She is a senior health economist at the World Bank. She'll be doing a 25-minute session first, and then we'll move to Octavio Gomez. Octavio Gomez is a faculty member at the Instituto Nacional de Salud Pública de México, the National Institute of Public Health in Mexico. He is, I must say, he's a former student of mine. Okay, from which year do you think? When was he my student? Last year? Octavio is sitting right there. Okay, when was he my student? 1907. There's one guess. Octavio was my student, 1988, 89, something like that, late 80s. Okay? And I've had the pleasure of working with him in Mexico. As far as I know in this course, he is the only person who is teaching, who has actual experience working within a Ministry of Health. So he worked for 6 years as Director of Evaluation in the Mexican Ministry of Health, and will provide you some examples from the perspective of a government official as well as from an academic. So it's my pleasure at this point to turn it over to Edith.
Thank you so much, Michael. I'm starting my timer. And thank you so much. Indeed, I have not worked within the Ministry of Health, but I've worked with lots of ministries of health. So we're fully complementary with Octavio. It's a pleasure to do this session with you. First of all, welcome to you all. This is your last day, I know. This is my last and first session with you. So I hope to get to learn a bit from you in terms of what you're looking for. A rainy day, but I think it's an exciting day because finally we can actually put a perspective of why evaluation does matter for you. Sitting, no matter where you sit, Ministry of Health, Health Insurance Fund, regulatory body within the sector. We need to understand what you can do with evaluation, how do you do evaluation to make it meaningful. So first of all, let me just find my flipper. So these are the big questions for the session. It's nothing, complicated. It's not rocket science. Why do we care about evaluation, right? And why do we actually care about measuring progress towards universal health coverage? And the next question is, how are these done in a practical manner and in an effective manner, right? And we're going to be presenting two very simple cases. One of them is from Kenya to resonate with the low-income countries or middle-income countries. And the other one is, it will be done by Octavio. So here we go. What is the session's objectives? We want to learn about the role of evaluation, right? What it does for health system design, what it does actually for managing health system reforms, and actually how you can use that as an accountability tool, right? Second, we're going to be discussing different options for evaluation methods, what kind of methods you can apply to different contexts, right? And then third, through the examples with Octavio, we'll look at how complementary these different tools are and how transformative they can be actually for your system management or system reform. And last, because each and every of these evaluations actually does something for the UHC, we are on a UHC platform, we can also tell how they actually transform the UHC design cycle. The last point I'm going to leave to Michael because he's going to do the presentation in the afternoon after lunch, measuring progress towards universal health coverage, right? What kind of techniques you can do to do that. And now, as a bit of a sort of icebreaker or brainstorming video, I'm going to assign just one question to each and every table. We need to be quick because my time is also ticking on the whole session. So please, from counting that table, 1, you answer question number 1. Second, question number 2, 3, 4, 5, 6, and 7, right? You counted yourself, right? Remember, now you start again. 1, 2, and 3. Okay, I give you 3 minutes because these are very simple questions. And I just want to do a bit of a baseline, with you, understanding what you're thinking right now about these questions. So I give you 3 minutes, and after that, we're going to have a quick round around the room and at the tables, what you're thinking about it at this baseline level at the beginning of the session. 3 minutes, okay? And counting. Is it clear, right, what you need to answer? 1, 2, 3, 4, right? By the table. So, are you answering the question?
Yes.
Okay, ladies and gentlemen, I know it might not have been 3 minutes, but given the time pressure, I would like to tap into your wisdom. So, table number 1, what was your question? Please read out, and if you can appoint one respondent. I can give you the mic, please.
There you go.
Okay, we are from the group number 1, and the questions is, hello, can I get your attention, please? Sorry. The questions was, how do you define evaluations? And evaluations definition is an systematic assessment that of a design and implementations and the result of intervention that have been done or progressing towards its end. I think it's the point is like a systematic assessment of a result. Yeah.
Excellent, very good. I'm not saying anything for right now. This is the baseline assessment. We should be testing you after the session. Okay, thank you so much. Thank you. Next group, please.
So the question we were responding to was what evaluation methods we're aware of. Just a couple examples. One was impact evaluation, where you have a control group, and we'd use that when we're looking for statistical findings. We talked about iterative or adaptive evaluation, where you're sort of building upon your approach and you're looking at the changes. Formative evaluation, when you're sort of coming up with trying to conduct an assessment of something. And then qualitative evaluation, the use of focus groups, the use of interviews, and that sort of thing, to to round out statistical findings. Just a few examples.
Excellent. Then you should be teaching this session, okay? Thank you. Thanks. Next group, number 3.
The question for group number 3 was, what is evaluation used for? For every program and policy, there are outcomes predefined. These are the achievables. So it's measuring of outcomes so that we can know, are we going in the right direction or not? And if not, then can we use some corrections and go in the right direction? Or the evaluations can always be used for next policy or next programs.
Just one cue, one hint in terms of when you use it, what kind of tool it is, right? Can you use it as a management tool, for example, a policy tool, a diagnostic tool, right? So think about as a tool, evaluation in different contexts, how you can apply it, depending on the unit that you're sitting or the level that you're, looking at. Okay, thank you so much. Thanks. Number 4, please.
So for our group, the question was, what is the evaluation used for? But I guess previous table has responded particularly to that. It's just like we discussed this one. So it is used to assess if a program or intervention was implemented right or going in the right direction, and what adjustments or modifications need to be made depending on the results.
Okay, I think now we're looking at the same thing. So if you can look at the next questions, how does evaluation support your work? How does it support your health system strengthening, right? Thinking about not only what the rules and what the framework is, but what is it that you can do with that tool, right? How does it support you? Do you have any comments on that?
How does your organization use evaluation for decision making? In my country, we have really done some group of indicators for PHC and hospital based in quality of the services, based on resources, measurement based activity by doctors in PHC, and also patient satisfaction. And we make our decision in micro and macro level, management type of decision.
One cue here is that, when you use the evaluation, is it integrated within your decision-making processes? So is it a systematic tool that you actually incorporate into your decision-making processes, right? Be it a Ministry of Health or so, yeah. But, you factored in the 5 minutes for the group work, right? Like so.
So our question was related to the resources, if it's enough resources and what constraint exists and what we have to do. In general, evaluation is used as a tool, but in different interventions, and of course with different success. And at the governmental level, for instance, due to fragmentation of different units and different responsible structure, this creates some scarcity of resources. First of all, it's financial resources and human resources. So capacities to formulate and to target very correctly what is necessary to evaluate, to assess, and after to take a decision, it's still problematic. And another, because our main agency involved, for instance, health insurance company, which has own purposes, Ministry of Health, providers, other international donors. So it's also not very efficient use of resources. So next step is to make much more clarity, much more focused, much more targeted, and by this to have much more efficient use of resources.
Excellent points. I really liked it. It's very important that, once you do evaluation, make it a very synergistic and very systematic, right, across different agencies as well. Thank you so much.
Our country just started the journey to the UHC. That's why we have good progress, but not that much significant as we would like to. So we want, so we have quantitative measurements, which according to which we can understand either we on the right way or not. So this is the number of declarations signed by patients with their family doctors. This we can measure in real time basis. A number of facilities which were already contracted by NHS and the amount of money they got. So the number of prescriptions which cover the primary care needs of doctors. So this is, we also can understand by PACS and by money spent. And we also have the survey which is supported by the World Bank. Now this is Health Index. This is a regular survey during the last 3 years. The level of satisfaction of customers by their access to health service, the quality of health service. So it's really interesting to monitor the level of satisfaction. It's really growing.
Excellent. So I think you made a point that it's not only sort of one side, the provider side, not only routine system, but surveys actually looking at the patient, right? So UHC, Michael is going to talk a lot more about it. I'm not, pausing that, but I think I wanted to open up the space to see where you are, what you're thinking about evaluation is, and understand sort of, what is it that we can do with evaluation as a tool. It's very important. It's not only a tool for, for the sake of, evaluation, but actually a very important management and policy tool. So because we are short of the time, the questions about why do we care about actual evaluation. These are the questions, these are some of the responses that, I was looking for when we went through this exercise. To inform decision at every level, technical, management, policy, and political levels, right? It's really important that you can use this as an effective tool. The second one, to improve program, policy design, and implementation, right? So when you do evaluation, it's not only, at the end point. You actually need to be very strategic, very systematic, that you start it early on, because otherwise there is no point. You might start evaluation too late to influence the whole process, right? To build some evidence, you might have a very complicated new trial. You might have a very complex new reform. You need some kind of, factual evidence to be able to base your arguments with Ministry of Finance, with whoever that you need to, convince. And for sustainability, how many times we have seen reforms that actually they were piloted very hastily, and out of the pilot there was a bad design actually which was scaled up, and later on it became a sustainability crisis. So if you don't do the evaluation upfront, you're going to be actually paying the price in the long run. And so one of the points, and I think Octavio is going to be talking about that especially when you have political changes, big systemic changes, you need evaluation even more so to be able to stand the ground, right? So the question is not even how to do evaluation. Everybody can do one kind of or some kind of evaluation. The question is actually how to do an evaluation that matters. And I actually sent some of the responses there, but it's not enough to have a robust design. It's not enough to have, some good gadgets to collect the data with. It actually is your systematic thinking of who is the uptake going to, how they're going to be managing that information, how are they actually acting on that information in a very strategic manner, right? So all these questions like, how can you be sound technically? How can you be strategic in terms of when and how you, start and resource your evaluation? And how can you be agile? We do not need to stick to a route if it's not working. We need to be able to adaptive and strategically, changing course if need be. And that's the point of evaluation. So you need to know which methods to use. And then our colleague, she was pointing out all the methods that you need to be aware of. Know what program it is informing very specifically. Sometimes we start evaluation, we are not even clear about what we want to have an impact on, right? Know who the evaluation is informing, right? Keep very strategic and close engagement with those folks. Ensure that the results are actually used. I mean, what is the point of having a report on a shelf? I think, it's a sunk cost, right? And then finally, understand the resource and institutional requirements for that. If there is no institutional support, if there is no political support, there is no point actually sort of doing, huge costly evaluations. So the basic definition, you actually talked quite a lot about it, and I might not go into the details, but practically we want to break it down into two big sections. You've seen the acronym M and E. One is obvious for monitoring, and the other one is evaluation. Monitoring is more of a descripting and sort of passive tracing of progress towards some, on an initiative, towards some, objective, right? But when evaluation comes in the evaluation, you look at the significance of activity or policy. You look at actually 4 very important dimensions within that significance. And I would like somebody to read those out. Maybe you in the front, please. So what are these 4 dimensions that we need to pay attention when we look at the significance of an intervention?
Yeah. Relevance.
Yeah.
Efficacy.
Mm-hmm.
Efficiency and sustainability.
Yes, so I just wanted to ask you, how many of you do have or have you done a bank project, and how many of you have you done an implementation completion report? So I see a couple of hands. So then please, yes, which country is that? Okay, Kosovo. So an ICR, final report, an implementation completion report, is actually looking at your project effectiveness on these very specific dimensions. Is your design and implementation relevant, right? Is the project actually effective or efficacious? Is it efficiently done? Are you using the resources that you have for that in a meaningful manner? And finally, is it sustainable? All these questions are super important, and evaluation does that for us. And so within the context of the flagship course, of course, you look at more intermediate results and management relevant results with monitoring, but then you look longer term results through the evaluation component. The types we looked at, you can classify it in different manners. For me, practically speaking, you use monitoring and evaluations in many of your routine, monitoring systems. HMISs, right? Many of the system, built in, and platforms that you use, dashboards that you use as well. They look at whether sort of one kind of indicators that is your variable of interest. Is it improving over time? Is the direction is the right direction? But I emphasize it. This is actually, it's like a temperature check. It's descriptive in nature. So descriptive statistic is, it's very nice, but you don't really know what is causing the change over time, right? So it's nice, but it might not be as helpful once you need to design a policy response to that. The second bucket, and I'm seeing a hand there. Do you have a question, please? Yeah, please, go ahead. Yeah.
Evaluation, I just want to know, of course, it is like end of a project or midterm or whatever. What is the right time to do an evaluation? Like after how many?
Excellent point, and I see I nearly need to finish, so I'm going to answer it very quickly. Actually, what my emphasis, and towards the end you will see the final slide, evaluation is running through the policy cycle, because you have formative research, as our colleague defined it. With formative research, you start understanding what are the things that you need to act upon, right? With operations research, you do it as you were doing, for example, a pilot experiment, because through a pilot you understand how to do things more effectively. You don't want to scale up something that is not meaningful, right? So I would emphasize that actually with evaluation you need to do it throughout the policy cycle. It's not a beginning and end. It's actually a continuous process. That's my point. And that's why when you look at these three components, monitoring and evaluation, a bit of a passive thing, operations research, a lot more focused on a very specific, making sure that the one program initiative, one pilot initiative is actually implemented effectively and efficiently, right? And the third one is a longer term thing. And it's not only longer term. I need to wake up, raise my phone. It's not only a longer term thing, but practically it's looking at a causal impact. And the causal impact is important because what we said that monitoring and evaluation is only looking at whether practically you're moving towards a target, but it doesn't tell you whether it's actually the intervention that is making the difference. Here, you should be knowing whether it's the intervention that makes the difference or not. And this is a cheat sheet that I will leave with you. What you do through monitoring and evaluation, operations research, and the third component is impact evaluation, is, who does that? When is it done? What is done during that process, right? Why it is done? And what kind of methods you're using? And actually the final questions for who, and what is the policy uptake from that? It's a bit busy slide, but you're gonna get the results. I give you one example. When you do a monitoring and evaluation, it's an ongoing routine process. When you look at it during an operations research, it's practically prior, it's independent third party, or actually a program could be looking at that component. If you look at impact evaluation, then you also sort of see typically it's an independent third party looking at from outside, right? So look at when is it done, who is doing it, what is happening during the time, and the complexity. I would want to emphasize, if you do recall your lecture from Marley, she was doing lectures over the weekend. She said that this is now the 21st century, and I do say the same thing. If you use monitoring and evaluations, it's very beautiful, it's nice, but it's nearly sort of archaic in a sense if you don't combine it with something else. We have a lot of technology, we have a lot of technical sort of resources to be able to do more proactive evaluation, more predictive evaluation, much rather than reactive evaluation, which does not help you immediately. And I think, that would be one of the central messages of this story, that, evaluation has different methodologies. You need to be able to combine them, and also you need to be forward-looking to the 21st century, that what are the methodologies, these predictive and, prescriptive methodologies that you can use to understand how you actually make sure that your sector is working. One example. If you looked at, the Googles and Amazons, and the Marilis was saying that, these organizations actually invest a huge amount of money into predictive technology. Imagine if you understand that your service delivery could be improved, because I do know the risk of a certain target population, and I can predict that that person would be coming in for services, and I can tailor the production function, and I tailor the service delivery to these people. If we don't do that, our service delivery is going to be delayed, or it's going to be more costly, right? So I think one of the costs, the key message is that, evaluation has many different tools with different complexities. Of course, it requires a lot of, resources in terms of human resources, skills, and also political support behind that. But if you do that in a meaningful manner, actually, it returns on the investment. These are the key messages from Octavio, so I will not say that. Engage early, obtain support politically, have the right technical skills, ensure that there is uptake of the results. There is no point of evaluation if there is no uptake from that. And then mainstream the evaluation if you can. I think at this point, I'm going to sort of skip it, because, obviously Michael will be talking about the UHC, how you measure that. I actually wanted to have a small illustration of a globe, of a, local use of UHC measurement. Among the two techniques, we have a country-based technique to look at the progress towards UHC, and there is a global methodology. Our colleagues in the DAC research department, they actually have been looking at the global databases, how you use global databases to do benchmarking and progress towards universal health coverage. What we looked at in a lot of country cases, and these are impact evaluations, looking at, a country context, like, actually, is, for example, in Kenya, patient safety, satisfied? And what they found is 3% of the facilities actually lives up to the minimum standards. And out of that, there is a whole regulatory process, starting. There is a whole evaluation process starting, coming up with new scores, scorecards. And out of that, actually, the evaluation becomes a very critical ingredient, a catalyst in terms of very important reform in a country. I think that's an example that, evaluation is not for the sake of evaluation. It's a very important tool to actually inform that, important process. Let me go through to the final slide, so that I can respond to our colleague with that question. How does evaluation link to the control norms, right? It does enter actually at every step of the way, right? It does inform the intermediate and the final processes, right? And then the final point, which I said that, where does it come and enter? It's practically throughout the policy making cycle. It is not a luxury. It is not a subsidiary to any of the functions that you analyze. And it actually should be the entry point where you actually do have system reform. I think this is my last point. And thank you so much for the patience, Michael. I'm like 1 minute over. Thank you so much. Bye.
Just one short introduction. Now, Octavio actually did it, Emily, and it was so powerful. I'm really interested to hear how it happened in Mexico and what was going on.
Thank you. And the presentation, where is it? Okay. Here. Here. Okay, thank you. Okay. Good afternoon. It is a pleasure to be here. I would like first to thank Michael and Nadim for the invitation to participate in what I would call now a legendary course. As Michael just mentioned, I'm presently working at the National Institute of Public Health in Cuernavaca, Mexico. I've spent most of my professional career there doing research and teaching health systems and global health. But between 2000 and 2006, I was the head of the unit for performance evaluation at the Ministry of Health of Mexico. So today I will discuss with you an evaluation strategy that was part of a major health reform that was implemented in Mexico between 2000 and 2006. And the main purpose of this reform was to expand social protection in health to 50 million Mexicans who were then uninsured. This is not going to be a technical presentation, it's a policy presentation, and I would basically like to answer three questions. What did we do in terms of monitoring and evaluation? What was needed to do what we did? And what remains of what we did? And my presentation has 5 key messages, which are the following. Monitoring and evaluation activities ideally should start very early in a process of reform because you need a lot of time to generate results that are useful for change. 2, monitoring and evaluation initiatives demand high-level support to finance them, to overcome the resistance that they usually generate, and finally to implement the recommendations that they produce. 3, evaluation is not easy. You require to do monitoring and evaluation activities strong technical abilities. 4, change based on monitoring and evaluation activities can never be guaranteed and is usually difficult to achieve. And 5, long-term sustainability of monitoring and evaluation efforts is an elusive goal and it requires very strong institutions. My presentation will be divided in 6 very brief sections. I will first present you with some background information on the Mexican health reform. I will then describe what we did in terms of monitoring and evaluation during those 6 years. I will then discuss some of the meaningful changes that we were able to achieve. In section 4, I will discuss what was needed to do what we were able to do and what remains of what we did. And I will finish my presentation with a set of conclusions. So let me start with the background information. As I mentioned a few moments ago, in Mexico we implemented a major health reform in 2003. It was approved by the Congress in 2003. And the purpose of this reform was to expand social protection in health to the non-salaried population, 50 million Mexicans, including those working in the informal sector of the economy, the self-employed, and the unemployed. And we were able to expand healthcare coverage with financial protection through a new public insurance scheme that is called Seguro Popular, or Popular Health Insurance. And this insurance scheme guarantees regular access to 250 essential interventions that are provided in outpatient clinics and general hospitals all over the country. This insurance scheme also guarantees access to 60 costly interventions, including treatment for all types of cancer in children, treatment for cervical and breast cancer, treatment for HIV/AIDS, and treatment for heart attack in adults under 60. As you can see in this slide, through Seguro Popular, we were able to expand social protection in health from 40 million in 2002 to almost 100 million in 2015. I think this is an amazing achievement. There are a lot of challenges, but these are the official figures. The total population of Mexico is 118. So we can reasonably state that Mexico is en route to achieving UHC in the near future. Now, the reform counted with several components. One of them was an evaluation strategy. And this evaluation strategy was based on a very simple framework, which counted with 3 components, one for each of the 3 basic levels of a health system: an organizational component, a program component, and a policy component. First, our intention was to monitor at the organizational level the way in which personal health services and public health services were being provided. Second, at the program level, our intention was to monitor and evaluate the most important programs of our administration. And finally, at the policy level, we intended to assess the general performance of the national health system and the general performance of the 32 state systems using various indicators. We assumed that the information gathered through monitoring and evaluations of the organizational component would be basically useful for management purposes, and that the evidence and information gathered through program evaluation and health system performance assessment would be useful basically for decision making at the highest levels of the system. We also assumed that all the evidence and information gathered through all these procedures would be useful for accountability purposes. Now, let me discuss in some detail each of the three components. At the organizational level, our intention was to create 3 annual reports. A report that would monitor the way in which ambulatory outpatient services were being delivered. An annual report that would monitor the way in which hospital services were being delivered. And finally, a third report that would monitor the way in which public health services were being delivered. Unfortunately, we only had the resources and the time to implement the second component, the Observatory of Hospital Service. And we published 3 annual reports. This is the cover of one of the reports. And this report, which is called in Spanish Observatorio del Desempeño Hospitalario, had basically 4 sections. The first section provided general information on resources and service of all public hospitals in the country. Number of beds, number of surgical units, available human resources. The second section offered information basic on safety, the accreditation status of each of the units, the disposal of toxic waste, and the frequency of hospital-acquired infections. The third section, which was probably the most important one, was devoted to quality of care. We identified 6 crucial hospital interventions: births, C-section, appendectomies, treatment of pneumonia, and for each of them, we measured the average length of stay and the number of readmissions or complications. And the fourth section was devoted to satisfaction. We implemented annual responsiveness and satisfaction surveys, and we gathered information on prompt attention in emergency rooms, satisfaction with the communication with providers, and satisfaction with access to social networks in case of hospitalization. The information for this report was gathered through the regular information system of the Ministry of Health, but also, as I mentioned before, through these responsiveness and satisfaction surveys that we were able to implement. Now, at the program level, we basically did 3 very strong external evaluations of probably the 3 most important programs of that particular administration. An external evaluation of a maternal and health initiative that was called First Start in Life, an external evaluation of the National Crusade for Quality of Care, and finally, an external evaluation of the most emblematic program of the administration, which was the evaluation of Seguro Popular. The first 2 evaluations were implemented by researchers from the National Institute of Public Health. For the third evaluation, we hired a group of researchers from Harvard University, headed by Professor Gary King, and they were supported by a group of researchers of the National Institute of Public Health who were basically in charge of gathering information. This external evaluation of Seguro Popular also counted with an external advisory committee, whose goal was basically to supervise and monitor the design and implementation of this external evaluation. And this external advisory committee included experts in social development initiatives from national and international academic institutions, researchers from national and international foundations, and 1 researcher from a multilateral agency, UNDP. Now, let me give you some detail regarding the most important of these evaluations, the evaluations of Seguro Popular. We had two types of evaluations for Seguro Popular, an observational evaluation and a controlled or randomized evaluation. With the observational evaluation, the basic idea was to follow a set of indicators related to Seguro Popular, to follow the values of these indicators. And we did an initial measurement in 2002 and a follow-up measurement in 2000, the first follow-up measurement in 2005. And the basic idea was to have values before and after the intervention. The problem with this type of evaluation is that you cannot attribute the changes in the values of these indicators to the intervention under study, which was Seguro Popular. For that reason, from the very beginning, we decided also to implement a randomized controlled evaluation, which would have a baseline measurement in 2005 and follow-up measurements in 2006, 2008, and 2010. The beauty of a randomized design is that you can compare over time households that receive an intervention, in this case affiliation to Seguro Popular, with very similar households that do not receive this intervention. We did this because we took advantage of the fact that enrollment to Seguro Popular would take 7 years. Now, the beauty of this type of design is that you can attribute the changes in the values of the indicators you're using to this particular intervention. And what we did in the case of Seguro Popular is that first, initially we identified 1,000 paired clusters in the 7 states that were willing to participate in the evaluation. We define a cluster as the population unit associated to a health facility. We then randomly selected 100 paired clusters in these 7 states. And this pairing procedure was made using a set of 50 demographic, socioeconomic, and health indicators. We then randomly assigned 50 clusters to the treatment group, which was the group that would receive the intervention affiliation to Seguro Popular in an initial phase, and 50 clusters to the control group, the clusters that would receive affiliation to Seguro Popular further ahead in the process. And finally, we've randomly selected in each clusters 340 households to be surveyed to gather information basically on utilization of services, financial protections, and some health outcomes. We did an initial measurement, the baseline measurement in 2005, and the first follow-up survey in 2006. There is something interesting in the decision to make the first follow-up measurements just 11 months after the starting of the evaluation. In fact, the External Advisory Committee opposed this decision, arguing, I think very reasonably, that the intervention period was very short and that we wouldn't find any changes in the values of indicators. But there was a strong political issue in that particular decision. Can you imagine which one was this? The decision to make a follow-up measurement only 11 months after the baseline measurement? Well, we were having elections in 2006, and we wanted to guarantee the sustainability of the program. And the surveys showed that the president of Mexico would very probably be the mayor of Mexico City, Andrés Manuel López Obrador, who, by the way, was elected president of Mexico a few months ago. And as mayor of Mexico City, he had consistently opposed Seguro Popular. So the Minister of Health thought that the only chance of survival of Seguro Popular was the existence of strong evidence that could support the survival of the program. So we decided to go on with this first measurement. What in reality happened is that Andrés Manuel López Obrador lost the election. The same political power stayed in power. The same political party stayed in power, and Seguro Popular survived. Now, what were the findings of these first follow-up measurements? First, that the program resources were reaching the poor. Second, that there was an increased utilization of health services. And finally, and most importantly, that there was a reduction in catastrophic health expenditures in the treatment group. The findings of these evaluations were eventually published in an article that appeared in the Lancet, which, as you probably know, is one of the most important medical journals in the world. Now, what happened with the third component of the evaluation strategy, the performance assessment? What we basically did is that we took advantage of a framework which is very similar to the flagship framework, which was used for a while at WHO to assess the overall performance of the health system using basically three types of indicators. Indicators related to health conditions, indicators related to satisfaction or responsiveness, and indicators related to fair financing. And what we basically did is that we made comparative measurements of these health indicators among states. This is a type of information that we published in an annual report, which I will show in a few minutes. This is maternal mortality by states in Mexico in 2004. As you can see, there are huge differences in mortality between the poor and the richest states of the country. We presented information on responsiveness, which has, according to WHO, 7 domains. The way in which users of health services were satisfied with dignity, communication, confidentiality, autonomy, conditions of health facilities, and access to social networks in case of hospitalization. This is a comparison among the main public institutions in Mexico. And finally, we presented information on financial protection. This is the prevalence of catastrophic health expenditures in 2002 by states. This information was published. There were printed and electronic copies of this report in a report that was called Salud Mexico, Health Mexico. We published 5 of these reports. And one of the most interesting aspects of this report is that we were very lucky. The president himself was able to present each of the 5 reports. This attracted a lot of attention. And this is the type of reaction we received from the media. This is the front page of the most important national newspaper, Reforma, and it's publishing and analyzing the information we had presented in the report of that particular year. Well, it's talking basically about investments in health, and it analyzes the differences of investment in health by state. And what you basically didn't want to happen if you were a minister of health at the state level is to be in the last 3 places, because the governor would call you and would tell you you were in the last 3 places in 50 of the 60 indicators of Salud Mexico. I don't want that to happen next year. So it was a very powerful instrument, especially because it was disseminated by all types of media, TV, radio stations, and all the local and national newspapers. Excuse me? Tiene México rezagos. Mexico has a backlog in health investment. And Mexico assigns 2.8 points of GDP in 2000 to health. The average investment in health in Latin America is 7 points of GDP in health. Mexico, even with the reform, is just investing 6% of GDP in health now in 2018. Now, did we achieve meaningful changes, which is the purpose of this type of evaluations? I would say that at the organizational level, the impact was very low. Even though we presented these reports, there was very little feedback with those responsible for managing hospitals in Mexico. The evaluation of Seguro Popular had a lot of impact politically. It gave the program a lot of legitimacy. And I would say that the annual report, Salud Mexico, Mexico Health, was very useful to improve performance at the state level. Now, what was needed to do what we did? What was needed to be able to implement such an ambitious evaluation strategy? I would say that 5 things explain this relative success. One, there was a legal framework. We were very lucky during the first year of the administration. 2 important laws were passed by the Congress. A law of access to public information and transparency in 2002, and the social development law, which created the National Evaluation Council, which coordinates and monitors the evaluation of all social programs, which are now obligatory. 2, there was a high-level commitment to transparency, accountability, and evaluation. Commitment not only from the Minister of Health, who had recently returned from working at WHO, where he had contributed to the design of a framework to evaluate health systems, and commitment from the President himself to accountability, to transparency, and to evaluation. Both of them believed that these were crucial instruments to guarantee the success of public policies. This high-level commitment translated into a strong institutional and financial support. I can give you just an idea of how many dollars we invested just in the randomized evaluation of Seguro Popular. We spent in the baseline measurement and the first follow-up measurements around $3 million. And another expression of this support is that the evaluation unit was part of the Health Information Office of the Ministry of Health before the year 2000. And the Ministry of Health turned this tiny office into an independent office with its own budget. 5, another thing that explained this success is in-house technical expertise. I had a team that counted with 2 PhDs in epidemiology, 3 health economists, 2 experts in health system, and an actuary. And we also had strong links with academic institutions that had been involved in the evaluation of social development policies. I think these 5 factors explain much of what we did between 2000 and 2006. What remains of what we did? Well, as you can see, the long-term sustainability of these efforts is very difficult. The following administration supported most of our instruments. In fact, they strengthened the organizational component by adding an annual report on ambulatory services. But then a new political party took power in 2012, and basically all monitoring and evaluations disappear, except for all those that are legally obligatory. I would conclude with this table that explains what can happen with this type of initiatives. And one of my conclusions is that these efforts depend a lot on the personal interest of the President and the Minister of Health, the commitment to transparency, to accountability, and to evaluation. In our case, there was a very strong commitment of the President, President Frank, and the Minister, not only to accountability, specifically to evaluation. President Fox and Minister Frank. He's now the president of Miami University. That's probably why I made this mistake. Then the following administration, the president was very committed to accountability, but the Minister of Health was not very interested in monitoring and evaluation the health programs. And then the PRI, the party that stayed in power for 71 years before the year 2000, came into power, and basically all these efforts disappear. Neither the president nor the present Minister of Health are interested in these types of evaluation. And now a new political party came into power, Morena. It's a leftist power, has a long tradition of authoritarian attitudes, and my prediction is that they won't be very interested in taking over this type of activities. Thank you very much.
we have 20 minutes. You can give me the. We have 20 minutes left, and so both Octavio and Edith are here to take your comments and questions. So I would just want to underline a couple of points that Octavio made. Leadership matters. Okay, your immediate boss, your minister, and the head of your country, the values that they have, the public commitment to process, and the commitment to evaluation makes a difference. If you don't have that kind of top-level commitment, it's difficult to do serious evaluation because serious evaluation has risks. Part of the goal of evaluation is to identify problems, okay? Areas that are not going well. That's point number one. Point number two, so I was in Mexico at this time. I was in Mexico 2005, 2006, at the time when Octavio was head of the Office of Evaluation, at the time when Dr. Frank was the Minister of Health. Okay, it was a special time for change. The people who are in positions make a difference. So the second point is that what Octavio didn't mention is that he has a close personal relationship with the minister. Okay, so that means two things. He had access to the minister much more than other people might. And number two, the minister chose him to be head of the office of evaluation because he wanted someone in the office of evaluation he could trust, and someone who would do a serious and good job. Okay? So, evaluation, you have to look at it not just in terms of who's in power, but the personal relationships. And we'll come back to this again in the next session when we talk about evaluation. And the third point is that when you change the parties in power, when you change the people who are in power, it changes the context, the values, and it makes it difficult to have continuity. One of the biggest challenges, I think one of the biggest questions for any reform, and after this I'll stop here, is do you have continuity in policies when you have a change in political power? Okay? This is true everywhere. It's not just your countries. You're sitting here today in a country undergoing an election. Okay? Where there are serious efforts to change the policies under Trump. He's done much less to change the Obama reform, the ACA, than he says he has done. Okay? But depending what happens today, we'll see what happens to the U.S. health reform. It took 100 years to get the U.S. health reform. Trump is trying to change that. And the same in Mexico. Mexico has a new political party in power. What happens in the next year is going to be critical to what happens with the Mexican reform. And the question is who's going to evaluate that. Okay, that's my end of my speech for now. Questions, comments from you on evaluation? I'll let Octavio, I'm going to let you. I'm not going to. Do you want me to manage this? Yes. Okay. Joachim?
Yeah, what are the results, the evaluation results on Seguro Popular? And how is it under today's political leadership?
Well, Seguro Popular has been evaluated from many corners. There was this initial evaluation done by a group of researchers of Harvard that showed positive initial results. And many components of Seguro Popular have been evaluated, and they consistently show that there has been improvement in health coverage, which is pretty obvious, improvements in indicators related to financial protection, but there are obviously a lot of challenges. Many of them related, for example, to quality. It's very difficult to expand coverage from 40 million to 100 million and provide the right resources, the right quality. So we're challenging a lot with quality of care. We have extended coverage, and I think that the present challenge is to accompany that extension of coverage with improvements in quality, especially at the ambulatory level in outpatient care. What is the status of Seguro Popular with the following administration? They intend to explicitly disappear it.
Eliminate is the word that they use.
One of the reasons is that, for example, they don't like packages of health services. They believe that the packages limit, that's what they say, the right to the protection of health. And Seguro Popular was very much designed around this idea of an essential package of services and a package of for resources for catastrophic expenditures. So they have a very strong intention of disappearing in it, and they have full control of the Congress, and they will probably do it.
So the answer is complicated story. All reforms take time. No one knows what is going to happen next. There's a recent article in my journal, Health Systems and Reform, done by the person who was director of Seguro Popular for the last 6 years, where he discusses what he has done, the changes he's made, the improvements, incremental improvements, but it is a complicated story. So the short answer is stay tuned. Okay?
I just want to thank Octavio for a beautiful presentation. Thank you so much. This is very close to my heart because actually my work is in M&E in Lebanon. And I know how political it can be. I know how some people in power would rather not have M&E because they don't want to know that things are not working. They don't want issues to surface. Now, throughout the week, I have noticed something. I've noticed it in Lebanon before. I knew it was out there too, but it was good to see the example from Nigeria yesterday, the example from Mexico. Things in developing countries, I'm not sure if it's the same for developed countries, they depend on people. So there's this one person who is an agent of change who believes, or a few people who come into power and then they make this huge change. And then politics change and everything is thrown out. I've seen it in Lebanon happen several times. It's happening now in Mexico, and it's heartbreaking. This is just something for us to reflect on. How can we safeguard our health achievements against such politics? Is this a reality that we should always accept and live with? I mean, it's just tiring to see that if a person comes into power, they can simply abolish everything we did. How can we make it sustainable?
Vote. Good question. Good question. So we'll go, Edith, do you have any thoughts? What does the World Bank say about how to protect policy reforms from political change and how to institutionalize good reforms so that they survive changes in political party? Maybe you can give some examples from reforms that have happened within the World Bank.
Thank you. Thank you very much for the excellent question. And actually, you said it, Michael. I think it really is institutions. So many of these evaluations that we have been doing, and I'm facing a gentleman from Nigeria. What is your name? Ibrahim. So we've done, for example, evaluations in Nigeria. We went through the same processes. Actually, that champion, that person who really sort of pushed the reform, it was at that point actually became the Minister of Health for State, Dr. Mohamed Pateh. He was coming to the World Bank that, we actually want to have the first reimbursable advisory services. We pay money for the bank to actually come in and evaluate something that we want to understand whether it's working or not. And that was a midwife services scheme. The question whether midwives actually deliver quality care, saving mothers or not, it was a very important question. 1 billion, lives saved, right? And I think the question really came at a time when there was a huge crisis. The oil subsidy was, halted, right? That was actually the Minister of Finance who was coming out of the World Bank previously as a vice president or a managing director, and she said we need evidence to be able to actually sustain that reform. But it's not enough to have the evidence and continue the reform. If you don't invest in the institutions to actually upkeep it, there is no change on a systematic and cyclical basis. So I think, and I haven't followed through, maybe you can comment on that later, that when there is a person strongly behind that, if you start building the institutions, for example, not only within the Ministry of Health and state ministries of health, but also getting in the research academia, which is the feeders actually to keep up that cycle in terms of evaluation and the investment of that, that's incredibly important. And I think Octavio made that point that it's not only one institution, one ministry, but the whole process behind it, how you connect to academia, how you actually get the voice of the citizens, right? Accountability from the citizen side. That's extremely important, and that's where I loop back to the point, voting with your feet, voting with your, actions as well.
So this is a key question, and I think part of Octavio's answer was they did the evaluation thinking about using it to create institutional continuity. Okay, so evaluation is not simply a technical exercise. It's also done with a political purpose of strengthening the institution with change on its way. So in Mexico, the periods and powers are 6 years. There's a 6-year term limit and no second terms. The president knows what he or she does. There's been no she's yet. As president, you have to think about what happens next. Okay? It's a dilemma. Okay, the dilemma is change depends on the individual, continuity depends on the institutions. Can the individuals build into their changes strategies for continuity that go beyond the individual? Octavio, I don't know. Yes, we'll go to Ibrahim.
Well, in my opinion, reforms, let's look at the World Bank, WHO, reforms take place, even the United Nations, the reforms takes place periodically, and they go on whether or not the chief of the organization is there or not, because the reform has to do with the institution itself. Therefore, the institution takes ownership of the reform. Now, in my opinion, yes, my question is, sometimes we centralize reforms on individuals. Yes, an individual can lead a reform, but he has to work with the system. And now the system is the people who are working within the system. Somebody can come from outside, lead a reform, but while he is doing that, the mistake he makes also is he also brings people from outside. More or less, they are ad hoc workers, as it were, permit me to use that word, meaning they are subject to political manipulation, meaning the government at that time actually brought them to institutionalize or to initiate the reforms. But they also bring people from outside.
Yes.
So at the moment they lose elections,
right.
they get out.
And the question is?
My question is, even in, my own opinion, in Mexico, probably when the office was set up, led by Octavia, if he had used people from within the system, who are already entrenched within the system, not coming from outside, therefore no political affiliation, perhaps it will be more sustained.
Okay, good question. Remember yesterday when we talked about the pharmaceutical reform in Nigeria? Okay, the first thing we said, Joachim said, bring in a team, create a team. So you're absolutely right. Creating reform and change requires a team. And usually the team is coming from outside. Usually. So the question is, to what extent can you build your team with the people who are there, who are not going to change when the top leadership changes? This is true in every ministry, every political, governmental organization, and different countries have different degrees of how many people change with an administration and how many are there full-time beyond. The people who are there who are part of the bureaucracy full-time, they look at the minister as, do you know what the word they use sometimes? The minister is a tourist. Tourist. He's there for a little while and will go on somewhere else. But the people who work there full-time, they're there for life. Okay? So how can you use the people in the bureaucracy for change? And can you use them for continuity?
The tricky thing in this particular case is that the team that I was able to organize stayed at the Ministry of Health. They left 2 or 3 years ago. But I mean, commitment to evaluation, giving money for monitoring and evaluation is a decision from the minister. So they were there, but they didn't have the budget. They don't have the budget. One last comment I would like to make. Michael has characterized the Mexican reform correctly as a minister-oriented reform. Minister-driven reform. And this is a very enlightened minister who had a very strong technical team who was able to implement this reform. But I think that one thing that we missed, we were never able to have the users of Seguro Popular own this initiative. They would probably be defending Seguro Popular nowadays, and we didn't do that work. I don't know if I have no political experience, but I think this is something we could have done. We were lucky in the first change of administration because the same political party remained in power and supported Seguro Popular. But as you can see, the support for Seguro Popular has been decreasing, and now it's going to disappear. And one of the reasons is because users are not organized and have not been able to defend this initiative that is basically benefiting the very poor.
This is a deep and important point that we'll come back to in the next session. Edith, do you have a comment on this?
Sure.
Speak close to...
Yes, so I will use one country without naming the countries in which I'm working in. And I think it's extremely important that we do use that internal opportunity. I wouldn't rule it out because that strengthens the system within. What we found in many of these contexts that actually the technical capacity might not be there. So investing in human resources, how many ministries, not in every ministry, but how many ministries you don't have very good health economists or data scientists, right? And so creating a technical skills, but also an institution for them to be hosted. So it's not a single person dependent sort of, reform, right? There is not a fixed effect because otherwise you're going to be in a, doldrum once that fixed effect is gone, right? So I think that investment is incredibly important. Another thing that I would make another point is a PPP. When we think about public-private partnership, bringing in academia, good researchers, you can actually augment the ministry's capacity while building it on the go. So I think I would not rule out. I think it's a very important, muscle to use it all angles within and also outside in terms of the PPPs.
Good, thank you.
You managed to achieve such incredible changes in the country. Was there a broader coalition, just apart from like a president and Ministry of Health? Were some other parties or stakeholders involved? This is like the first part of the question. The second one: what is the role of? Does it give any kind of immunity to the irreversibility of changes? So if it's not just the president, the Minister of Health, maybe there was somebody else.
As I mentioned before, it is a very good question. As I mentioned before, President Fox came into power when he won the elections in the year 2000, and the PRI, the losing party, had stayed in power for 71 years. So this was basically a democratization process. So there was a lot of support for whatever the president did. There was a lot of citizenship support, and even some of the opposition parties were in a coalition with them. So this helped a lot. Interestingly, when the law was passed to create Seguro Popular, one of the things that the minister tried to do in order to guarantee the sustainability of the program was to get all the parties support this initiative. And he was able, obviously, to get the support from the party in power, which was not his party, and the support from the previous governing power, which was PRI. But interestingly, he didn't get the support of the party that intends to eliminate Seguro Popular now. He wanted to do this in order to send the message that Seguro Popular was the product of all political groups in the country and not only an initiative from the particular political power, the party that was in power. So that's one of the reasons why the coalition eventually didn't work because it was not a full coalition. We weren't able to include in that coalition the people that were sort of our enemies and who are now in power.
Sort of our enemies. Well, it's a little bit stronger than that. And so there's, again, if you go to my journal, there's an article that Octavio has written. I'm also a co-author about the politics of getting this reform adopted. And so I think one of the key lessons here is that the politics that you use to get a reform adopted can affect the sustainability of the reform. Okay? So in this country, Obama passed the reform through some very delicate negotiations and strategies without the Republicans. The result has been the Republicans have opposed it ideologically at every chance they have, even though the technical aspects of the reform actually included ideas that came from the party of the Republicans. This is not about ideas. This is about political attacks across organizations. Okay. I think this has been a very rich discussion. It actually brought together a number of themes in the course. Anyone who's interested in more information about the Mexican reform, I'm happy to give you links to articles. I want to talk to you a little bit about, so Edith and Octavio, thank you very much. This has been really